right. Seems like we're good to start. I hope everyone enjoyed their lunch. It was so nice chatting with so many folks who are here. And thank you for those who are Zooming in from home and listening in on the webinar. I hope you take some time to put your questions and your comments into the chat, and hopefully we'll have time with our panelists to discuss those today. So I'd like to introduce myself. I'm Brianna Lombardi. I'm an assistant professor in the Department of Family Medicine at UNC Chapel Hill, but I'm a clinical social worker by training, and I direct the Behavioral Health Workforce Research Center at UNC Chapel Hill, which is a SAMHSA funded health workforce research center. And as a social worker, I'm so excited to be here talking about near-term solutions and really hearing from two experts about what their organizations are working on strategies to support health worker well-being. So I'll talk to you a little bit about where I'm coming from. As I mentioned, I direct the Behavioral Health Workforce Research Center at UNC Chapel Hill. We are within the program on health workforce at the Cecil G. Shep Center at Health Services Research. We also have the Carolina Health Workforce Research Center that's directed by Aaron Frayer, and we also have a large state portfolio where we look at North Carolina health workforce, and we get to have conversations with health systems and health professional training programs to have many of the conversations that we're having here of what are the impacts on well-being and retention within the health workforce in our state. But we are just two of the 9 federally funded Health Workforce Research Center, and I just put these out here for you so you all know that these health workforce research centers around the country that are funded by HRSA can be a support to you. Many of them are doing research on health workforce retention across the different disciplines, including allied health, oral health, long-term care, public health at the University of Minnesota, and obviously behavioral health workforce at UNC Chapel Hill. Before I go on, I'll just briefly introduce my two panelists here and also mention the objective of our session will be to feature local innovations, state-based strategies, and leadership behaviors that foster health workforce well-being as near-term solutions. And I'm here with Dr. Timothy Kowalski, who's a trustee of the American Osteopathic Association and Vice Dean for Professional and Public Affairs at the Edward Via College of Osteopathic Medicine, and Habib Sabah as a program manager of Physician Wellness Office at the University of California, San Diego Health. And so excited to have you both here. And so many of the conversations that we've been having today, I feel right as home here, and thinking about this issue within a systems perspective. And the first thing they teach you in social worker school is person and environment. And that's the first thing that they teach us, is that you can't look at an individual's symptoms in isolation, but you need to consider the cultural, social, environmental factors that are driving an individual's situation. And so too in the conversation that we've heard today is that we aren't looking at the individual healthcare worker and saying, what's wrong with you? But we're looking at the systems that individuals who are personally resilient are working in and considering what are the interventions at these multiple systems and what can we do about it. And so hopefully in this conversation of this session and later sessions today, we'll really talk about what are the interventions at these multiple systems and having this increased recognition of the system interventions to address health worker well-being. So I'll start with really thinking about health systems, and truly so many health systems and chief wellness officers are here in the room and online, that health systems have took a lot of the frontline work in thinking about how are they going to implement health worker strategies. And certainly from Habib, we're going to get to hear about UC San Diego's approach in their physician wellness office about how they are really targeting health worker well-being. And we heard earlier how important health systems are in developing a culture and a sense of community. And much of the research that we've also done at the Behavioral Health Workforce Research Center with peer recovery support specialists and graduate level behavioral health clinicians have similarly found that individuals who feel like their personal mission is aligned with the organization that they're working for, is supportive of their work satisfaction and job retention. And also will hopefully be recognized later today with the accelerator program, the poster session, but certainly the more than 400 organizations that have I've joined the Wellbeing Collaborative as an accelerator who are implementing these programs and evaluating them across the country, which is really exciting. And we'll also get to think about the role of professional and community organizations in thinking about how to support and advocate on behalf of the professions that are working in the health space. And we'll have Dr. Kowalski talk to us about how the AOA is working to address health worker well-being, and really thinking about how these advocacies have also developed work toolkits, communication strategies, and other mechanisms to get the word out about how to address and support health worker well-being. I'll briefly also mention that we need to think about state and federal policy solutions to support health worker well-being, and it's difficult to have these conversations about how we support the individual healthcare worker when we know that the pressures of funding cuts towards Medicaid will impact the workload of individuals who are on the front lines. But certainly, states and the federal administration recognize that in order to have a healthy and well-being community, we need to support healthcare workers who are also members of our community. And at the state level, some of the work we've been doing at the Behavioral Health Workforce and the Carolina Health Workforce Research Center is looking at state-based workplace policies, workplace violence policies, specifically looking at how states are trying to legislate their way into supporting / encouraging health systems to really take it seriously, workplace violence. And we've also been tracking how this has changed over time. And so previously, prior to the pandemic, it was highly focused on punitive or increasing the penalties for individuals who have committed workplace violence towards healthcare workers, but increasingly they're legislating things like prevention and remediation strategies. So an individual healthcare worker who was assaulted at work is able to press charges in a safe and sustainable way. That we are requiring health systems to implement safety strategies as well. And then really thinking about recognizing the role of the federal government in ways that they can support health worker well-being. And probably one of the most recent and one of the policies with the largest impact was the Dr. Lorna Breen Act, which funded over 100 organizations in producing health worker strategies, implementing them, but as well as kind of creating organizations that have been really thinking about this. As a social worker, I can't get out of here without saying also thinking about the healthcare team and really thinking about how we can push the solutions not just to the individual, the health system, or state and federal, but also how do we think about team-based health worker interventions? How does the well-being of the team impact the well-being of the individual healthcare worker? And at the Carolina Health Workforce Research Center, this is work from Aaron Freyer, is really thinking about how do we select or how do we support the healthcare worker over their life cycle or their life course. And we heard a little bit about this earlier today, is that likely the supports that a healthcare worker needs at their early career are going to be different than what a health worker might need at their middle or later career. And so thinking about how do we design interventions that are mindful of these differences across the health worker well-being. And then some of the work we're doing at the Behavioral Health Workforce Research Center for graduate level behavioral health clinicians is really thinking about supervision and early career support as a mechanism to inoculate or hopefully protect early career behavioral health clinicians in the work that they'll do. But so much of that is reliant on mid to late career behavioral health clinicians to be doing that at work. And so really being mindful that in order to benefit the early career, sometimes we really are relying on middle and late career, and how do we have to think about that holistically? I'm sure you all are familiar with this, thinking about the role of teams, and really thinking about not only are teams great for patient care, but also really thinking about how when you're a clinician and you know you can't meet the behavioral and social needs of your patients, how that can result into moral injury. And so really thinking about if you're on a team where you know that your patient's social and mental and behavioral health needs can be cared for by a team member who is qualified, how that could also support your role that you're doing, but also the alignment with your core values with the health system as well. So I'll just end it with really thinking about that. We've given you a few examples of some of the health system, professional organization, state and federal strategies that have been used, but you could probably see we haven't really been mindful about having a coordinated or an aligned approach. And so each of these systems have different policy levers, different abilities to address different things. And really thinking about how do we align our interventions from the health system up in concert. And so hopefully we'll have a conversation after our presenters talk about the work that they do to really think about what are the state and federal policy levers that could happen that could support the dissemination and the widespread implementation of these health worker well-being strategies. So thank you again. I'm looking really forward to having our conversation, and I'll have Dr. Kowalski go first.
Thank you very much. I want to thank you for inviting us today to discuss the ways that the AOA has mobilized partnerships at the national, state, and local level, addressing clinician well-being and ultimately improving healthcare quality and patient safety. The AOA is a national member organization representing osteopathic physicians and medical students across the country. We are thankful to the National Academy of Medicine for leading this important, innovative initiative focusing on multidisciplinary systems-level solutions. And we've been participating in this initiative since 2018 and committed to continue this crucial work. A little bit about osteopathic medicine. We are physicians, there's DOs and MDs, and we're licensed for the full practice of medicine. We practice in every specialty there is. We do have additional training in osteopathic manipulative therapy, and we are disproportionately overrepresented in our choice of practice sites. We are meeting our social contract with society by focusing in many of our grads going into primary care services and practicing in rural and underserved areas. We have a patient-centered, whole-person preventive approach to care, and we embrace helping patients to heal from within in body, mind, and spirit, emphasizing empathy, compassion, and a healing touch. Our profession has grown significantly in the last number of years, quadrupling in the past 3 decades. You can see how we've grown over time. And now we've, as Dr. Spiker mentioned earlier, over 40 accredited comms and 71 teaching locations in 36 states. We're 20% of medical schools in the country and well over 25% of medical students studying osteopathic medicine in the country. And our organization is informed by our Federation of State and Divisional Societies with specialty colleges. This is an important place for student osteopathic medical voice, and our advocates helping to inform our policy that guides what we do. Our new president this year is Dr. Robert Piccinini. He's our first psychiatrist to serve as president of the AOA, and he's also co-author on the publication for the NAM that was discussing osteopathic medicine and wellness related to that. He's continuing his work in this area by having established a work group to continue developing our approaches to improving wellness of our members. And he's really focusing on ways that we can do peer-to-peer approaches. He personally has developed the President is In series, Your Time with Dr. Bob, and doing town hall meetings and a series of get-togethers with students and residents, and also a unique series of Cooking with Bob series, since he's quite the chef and shares personal stories about mental health and other kinds of things that benefit our profession. The big thing that we've been working on over time and continue to advance is certainly our work with the National Academy of Medicine and participating in this action collaborative on clinician well-being. And we've developed a toolkit that really looks to develop areas that we'll talk about at the next slide a little bit more. We're also partnering with the American Foundation of Suicide Prevention and developing clinician training and resources, and also working with and partnering with leading medical organizations to assist physicians in combining medical and behavioral health services through integrative health delivery. Our advocates, the AOA advocates, have developed their Yellow Ribbon Suicide Prevention Program, and they've also partnered with the National Alliance on Mentally Ill, enhancing College of Osteopathic Medicine resources, as well as medical student and physician education. And this includes the 8 dimensions of wellness toolkit for our medical students related to emotional, financial, social, spiritual, occupational, physical, intellectual, and environmental health support. We've been busy in developing our own quality improvement initiatives and patient safety. Our wellness toolkit includes areas that talk about achieving wellness and focusing on understanding and preventing workplace violence, recognizing burnout, depression, and suicide, and also includes important things like resources for things like the physician support line was developed by one of our VCOM graduates, actually a psychiatrist in Philadelphia, as well as other kinds of things available. One of the things that we've done is, because we are a patient safety organization, we have taken advantage of confidential peer-to-peer education and support within this patient safety organization umbrella. Discussions on emerging and controversial issues, create a federally protected patient safety work product under the Patient Safety and Quality Improvement Act of 2005. So our physicians can get together, share with us what they're concerned about. We've learned some of these things by some of the resolutions that come through our House of Delegates, concerns about criminalizing care in practicing evidence-based medicine, prescribing medications, and the like. And so this provides a safe environment for folks to have these conversations, and we as an organization can figure out how we can best take that information and improve things. The thing that I want to talk about most, and I see this through my lens as a psychiatrist who's been practicing and working with the medical boards and the Federation of State Medical Boards for over 20 years, is recognizing the stigma surrounding mental health and substance use and fear of disciplinary action and loss of license, specifically related to mental health questions that have been described in the Lorna Breen. And in 2019, the Federation of State Medical Boards addressed this by adopting a policy on physician illness and impairment and recommending that their member boards limit the questions on the licensing applications to those conditions causing severe impairment only, and to allow for a safe harbor for licensees to voluntarily access confidential assessment and treatment. In 2019, our AOA developed policy urging state medical boards to offer a safe haven non-reporting option on licensure applications. And this is taking off around the country. For example, even Virginia has developed legislation at the state level creating their state safe haven program, and putting it in statute really is very, very helpful that way. Many other states have allowed for these anonymous tracks, but there's still more work to go. As has been mentioned, and we heard earlier from a member of the Dr. Rip, board of the foundation of the Lorna Breen Foundation, her death by suicide in 2020 really set things moving towards figuring out how can we do better improve that. And out of that came the Lorna Breen Healthcare Provider Protection Act, which Brianna mentioned that is coming up for renewal. We have been a strong advocate of that, visiting legislators on the Hill to promote that. And also in their All-in Wellbeing First Healthcare Challenge was launched by the Lorna Breen Heroes Foundation to change these licensing board questions. And here's a map showing all of the states that have achieved changes in those intrusive questions from the medical perspective, and it's starting to expand now in pharmacy. There are 9 states that pharmacy boards have changed. In 6 states, nursing boards, licensing boards have changed. In 5 states, the dental boards have changed these questions. And it's starting to also impact credentialing applications in hospitals and clinics and the like, over 1,800 around the country, and even locums tenens applications, and some insurance companies are starting to catch on, but obviously there's more work to be done. And with that, I want to thank you for the opportunity to share a little about that which we are doing, and look forward to our continuing partnership with National Academy of Medicine. Thank you. Oh.
Should I skip past?
These are 2 extra slides that I wanted to point out that I got from F. Perry Wilson out of Medscape, looking at the fact that suicide is a major issue, certainly for physicians, but according to this most recent data published in 2023, we see nursing and healthcare technicians and other healthcare providers in the work environment that even have higher rates. And so it's something that when we come up with solutions for this, we need to make sure we can try to provide that for all of the members of our healthcare team. Thank you.
Good afternoon, everybody. I'm Habib Sabah from UC San Diego Health. I'm the program manager for our physician wellness program. UC San Diego Health is a regional academic medical center in San Diego County with 3 hospitals, about 20,000 health workers, of whom I'm charged with supporting our 1,700 attending physicians. I'm also honored to be representing the health system perspective in this discussion today as one of the 23 founding changemaker accelerators with the National Academy of Medicine's Clinician Wellbeing Collaborative. The topic of today's discussion is, of course, near-term solutions to uplift for health workforce well-being. I'm going to kind of give a quick overview of what to do, although the first session covered that definitely better than I will. I'll focus many of my remarks on how to do it, because that's what I do every day. I'm in that middle tier of the layers that Brianna showed with interventions, and then also just sharing some kind of pearls of wisdom. But you'll see these things are definitely going to be blended in my remarks today. So when we think about near-term solutions, first of all, I want to define near-term as 1 to 2 to 3 years. The reason I give kind of loose 1 to 2 to 3 years there is because, as we all know, there are some things that are low-hanging fruit that you get your innovators and early adopters to kind of jump on, and then we get those things done. But then some of those things, you start the work in year 1 and it has to go on to year 2, and then some things don't work, so then it goes on to year 3. But as you're figuring out what those things are to do, I recommend that folks, and of course, addition to consulting the literature, which we all in this room are well familiar with, really start with listening to your people. And it's been interesting to see in the past few years of doing this work at the health system level that the things that people volunteer and oftentimes will intuit end up showing up in the literature a little bit later, and then we come back to where we had started thinking about on our own. Now, I don't mean to say that we shouldn't consult the literature, because what it does is it normalizes what things that we think are us problems locally into things that people are more willing to accept and take on. And then furthermore, of course, going to the literature helps us see past intuition and understand deeper insights without having to learn those lessons ourselves. So recommendation for number 1, when you're thinking about, when our colleagues in health systems are thinking about what to do, I'd start with listening. And that comes with a number of forms, surveys, of course. Listening campaigns are fantastic. That's one of the recommendations by the American Medical Association in their Joy of Medicine health system recognition criteria, is to do a leader listening campaign. That has been fabulously successful for us, which I'll talk about a little bit later. And also, as we've heard through our colleagues this morning, some of the common themes that we're observing locally this year and that we'll work on over the next 1 to 3 years, you'll see on the screen here: administrative burden, physical safety, and connection to leadership. Come up in a number of ways. Intuitively, we think about physical safety, we think about clear and present danger, but also one of the things that we observe frequently, particularly with our inpatient units, is potential danger that has not yet been realized, but people who know the system intimately recognize this could be an issue, and could we please do something about it? Living with the anxiety in that situation. And then also connection to leadership. Very often we hear about, there are disconnections in communication, and there's one group that knows things really well and one other group that hasn't heard about it at all. But I think there are a couple of nuances with connection to leadership, such as perceptions of fairness in decision-making and resource allocation, confidence in the competence of leadership. Do people understand the consequences of their decisions? Am I invited to participate in decisions that are made that affect my work? And do I have representation in ongoing discussions and things like that? So those are some of the common themes that myself and colleagues at UC San Diego are seeing, not only locally, but also are reconciling in the national discourse and literature. And of course, those of us who are familiar with the National Academy's National Plan for Health Workforce Wellbeing will recognize some of the themes underlying these things. And we're students of the national plan as much as anybody else. So let's talk about how to do it when we talk about near-term solutions to uplift for health workforce well-being. The first thing I want to talk about here is implementation or physical transformation. There are 4 tactics I'd recommend. These things may seem intuitive, but I want to underline them. The first one I want to call out is have a strategy for health workforce well-being. Again, it sounds very simple, but when we often start with well-being work, we start intuitively with let's have a happy hour, let's host fitness classes, and that's not a strategy. A strategy is we have a vision or a goal, and we're going to chart a series of tactics that are going to help us realize our goal. And that involves data collection and analysis, and resourcing, and then structured, rigorous implementation, and finally, accountability, as in, did we achieve what we set out to achieve? That's how you define a strategy. I'd recommend that a well-being program, when you're thinking about near-term solutions, you need to have a strategy, and you need to follow up and see how it went. Another tactic I'd recommend is engaging your leaders. Of course, this is another intuitive one, but it connects to point number 3 here, which is forming a team of teams. I'm using General Stanley McChrystal's language here, team of teams. Maybe it's just because I'm most of the way through his book right now, which is fabulous and recommend it if you haven't read it. But necessarily, us in the Wellbeing Office do not have formal authority over the systems that control many of the factors that influence people's well-being. So necessarily, we must build partnerships and create advocacy and work together and ultimately have a team of teams. So I'll share in a few moments, but work very closely with our colleagues in information systems and facilities and clinical leadership and administrative leadership all across the board. And then finally, again, this is not going to be news to anybody, but I'd recommend communicating regularly. Now, we talk about communication all the time, but when I say regularly, I mean, can people predict, do they know when they're going to hear from us and about what? This allows people to engage who want to engage, disengage the folks who do not want to engage, but then that creates the cycle of accountability. I know that every quarter I'm responsible to report back to our 1,700 physicians, the people that I serve, to tell them what's going on, how have we been effective in serving their needs. So these are some of the recommendations I'd make for the physical transformation if you're thinking about near-term solutions. But there's a second side to it, which is revitalization or the emotional transformation that comes with work. Because you could do all these things, but let's say that nobody knew about it, or it didn't make a difference, or we fell to some of our own vices and didn't include people in decision-making. We did things because we learned something and then we didn't ask anybody and we did it. And they said, well, you didn't, you made a decision that affects my practice and you didn't include me. We can't, no, this is the thing we're trying to undo. So there are a handful of tactics I'd recommend here. The first in the top right, I'd recommend creating a trophy case. This might seem a little bit silly, but we all talk about as leaders having your talking points and making sure that you're well rehearsed and that they're coherent and they meet people where they're at. But well-being work, as I'm sure many of us know, comes in many, many forms, and there may be a lot of things that we may have 10 or 20 or 30 or 40 or 50 projects at the health system level, and eventually the CEO and our office are accountable to follow up and say, this is what got done. You said you need help in this, this, and this, and it's our job to make that happen. The trophy case makes that easy. And it also helps people understand, yeah, I did say that. And you guys listened and you followed up and you made a difference. And this is where we talk about moving through cynicism and restoring trust, revitalizing trust and emotional transformation of our workforce. I think a trophy case is a useful tactic for that. Also, bringing leaders and frontline team members together. When I had mentioned the leader listening campaign earlier as being a fabulously effective tool. What we did at the AMA's recommendation was we took our annual well-being survey results and met with every one of our 19 clinical departments in the School of Medicine and our community care practice, with the CEO of the health system and the CEO of the physician group and the dean of the School of Medicine and the chief medical officer, who, to their amazing credit, I'm very grateful to work with these folks. They really walk the walk, and it's a significant investment in time and effort. But you get to air it out. There's the folks who didn't participate in the survey who then get a voice. The folks who did participate in the survey get to validate their feelings. We get to reconcile together with a plan. We get the chair of the department hosts that meeting. Every department also has a physician wellness director. We talk about solutions together. Nothing about me without me. Y'all may have heard about that in our change management curriculum. Nothing about me without me. There's a fair amount of airing out of grievances, some cathartic comments on, I didn't realize that we had made this decision without you. I didn't realize that this decision had this downstream consequence, and I'm sorry. Talk about emotional transformation. This brief dialogue. Some of these meetings happen late at night, 8:30. We stayed with the orthopedic docs, very, very late in the evening, and it just makes a really big difference. So I'd recommend having people together in the room again. Nothing about me without me, to bring people together to talk about the issues and design the solutions. And then the last two I'm gonna combine: create accountability and then don't renege on well-being. I mentioned a little bit earlier about having predictable, pre-planned cycles for following up with communication. That's one of the mechanisms by which you can create accountability. And I think of accountability to whom? Accountability to the people we are serving. I serve 1,743 attending physicians at UC San Diego as of Monday, 1,743. That's the job. That's the obligation. So accountability comes in routine communication cycles. It also comes through routine, prepaid, pre-planned contracts with our survey consultant. So every year there is a survey, whether the administration and teams have been effective in designing and implementing countermeasures, whether we've been effective or not. There's going to be a survey, there'll be a dashboard, and that creates accountability for us. It also, of course, creates accountability for the leaders of all the teams who are responsible in this work, this team of teams I'm talking about. Because we may be really enthusiastic, for instance, about we're about to go live with ambient documentation system-wide. I am not a data engineer. I'm not an artificial intelligence engineer. Necessarily, this work is owned by our brilliant colleagues in information systems and our chief health information officer. And I need to do everything I can to make sure that is successful as a partner, because we both have a shared interest in the success of those programs. And that also creates this effective downstream of not reneging on the promise of well-being at work, because there's kind of two sides to this, the emotional transformation. I think this is known to folks in this room, but the genie's out of the bottle. we have talked about this work. We have made progress on this work. We've made promises and visible commitments to, the people who architect this workplace, your workplace, care about your experience at this workplace, and you can't withdraw on that because the song has already been sung. Now we'll talk a little bit about how to make that work real when it comes to parity between professional groups. But I would very, very strongly recommend, if you've already begun the work and make the commitment, don't delay, don't falter, because what we're moving through is cynicism into trust. And people who are cynical about well-being work, another flavor of the month, whatever it is, will be very happy to applaud your failure. So I very strongly recommend keeping it up. And again, folks who have read the National Plan for Health Workforce Wellbeing will see all of these values reflected there. Okay, a couple of lessons learned with my last few minutes here. There are two main things for if you're trying to bring well-being work to life at a healthcare provider organization. Thing number one I'd recommend is make it easy. I'm sure we've all had the experiences in here of, well, everybody's busy. We all have competing priorities. We all have limited budgets and funds, and our portfolios are all full. And by the way, there's not time to add well-being projects on top of all the things that I already have to do. So one of the things I recommend is to make it easy in two ways. One, align the values that you are purporting with the values that your colleagues institutionally have. For example, I mentioned our colleagues in information systems. Their job is to advance effective clinical technology. My job, in part, is to make sure that our physicians are excellently equipped and have minimal administrative burden, and therefore we find values alignment and goals alignment in that, if IS is effective in launching ambient documentation and we can reduce the burden of documentation for our doctors, that we have achieved the same goal, or we've achieved our mutual goals with the same exercise. I also recommend aligning on values. Dr. Kowalski used the words empathy and compassion. I'm very glad he used those words. Empathy, the exercise of feeling with somebody, with their feelings, and compassion, the desire to do good to others. I've had lots of success, I'm happy to be able to say, connecting emotionally with our colleagues about doing well-being work, their willingness to do well-being work, when we talk about empathy and compassion. When we bring things to folks, well-being programs oftentimes are watchdogs and spotlight issues, and people can feel defensive because this is something that came out of my shop and I didn't realize it was harming somebody. And you have to have, of course, a psychologically safe conversation in that way. But when you align on the values of none of us intend to do any harm to anybody, and all of us have this altruistic motivation, that's why we do this work. We could all go do easier work, I'm sure. We find that it becomes easier for folks to get on board. This is the right thing to do. Let's do it. And then again, institutionalizing well-being as a long-term value, a familiar one. The last thing I want to share here is the second big lesson learned is if you can make it safe for partners at your institution to take on well-being work, I think it's critical to building that team of teams, to building those internal partners. And I think there are a couple ways that you can do it. One, it's very easy to be a watchdog and say, hey, this came up in the well-being data. You've got X, Y, and Z problem in your department, and you need to deal with it. That's not a psychologically safe way of doing it. Here's a flaming package, jumping it on your doorstep. It doesn't work. The alternative approach I'd recommend is showing up as a supporting partner. Hey, you're resource constrained. This is important to both of us. How can I help? What can I do? What barriers can I remove? What teams can I put together? What things can I personally project manage to bring this to life? Because it's important to both of us. And, I brought a problem. Anybody can complain, Henry Ford. Don't find fault, find remedy. Anybody can complain. So I think that's one recommendation I'd have. Another one is reciting and believing in the self-compassionate phrase, we did what we knew at the time, and we know better, we do better. Maya Angelou, right? This gives people permission to move forward and do better. You just say that, I'm not holding you responsible for this or that. These are things, the world has changed so much that you could even say the world has changed. We did what we knew at the time, now let's do better. Let's do differently. And then finally, of course, there's a dynamic And the healthcare environment in general is dynamic. We see it every couple of years. Something affects our operating environment, and I think a standard that as a partner who's also championing a particular cause with health workforce well-being, we need to promote and accept the standard of doing the best we can with what we have. Some things get done the first year, some things don't. That's okay. We're going to keep marching. And with that, that's my series of reflections on behalf of UC San Diego Health and the National Academy's Changemaker Accelerator cohort. This is our website at UC San Diego Health Physician Wellness.ucsd.edu, and our program contact and my contact if you want to learn more about it. Thanks.
Yeah, wonderful. Thank you so much. I loved hearing about your applied examples, Abib. It's truly super impressive, and I can't wait to dive into some questions. And I'll open this one up as moderator's choice, but again, would welcome questions from those in the audience here and those online to ask about pragmatically what it means to implement these near-term solutions, problems that you're seeing. But where I'd like to start this conversation is thinking about any state or federal policies that you could think about that would support or inhibit the change that you're interested in making. And I'm thinking about the one you mentioned, Dr. Kowalski, about how we would hope individuals in the health workforce could reach out and connect for mental and behavioral health treatment, but that we had laws on the books that would prevent and punish, and we still do, individuals who do seek care. And so really thinking about, we can't just say, hey, let's expand access to mental and behavioral health care for healthcare workers without thinking about what are the state and federal consequences for doing so. And so that was a perfect example of how you thought about the solution of behavioral healthcare access, but also thinking about the state solutions. But I'll kick it to you first, Dr. Kowalski. Any other state or federal policy solutions that could help or inhibit change?
Right. Well, so we see the movement in trying to change the way information is gathered to try to make it a safer place to become licensed. But that's one thing about questions on licensing applications. The other thing I think is so very, very important is that every state has a physician health plan or a health provider health program. And what's very, very important is that we try to maneuver to allow our healthcare providers to move towards health if they need assistance with assessment and treatment. And if they get involved in that they be allowed to do that without any fear that the licensing board would find out and do something about that. That's a preventive approach. Obviously, we want to protect the public from anyone that would be so impaired as to practice in a way that could hurt them. But we want to protect our providers who the society has invested so much in them to keep them functional and healthy. And so, however, states can try to work with either the legislators like they've done in Virginia where they've codified it, or others to make sure that there is this anonymous option available. And to continue what's already been started on the medical boards. As you see, the nursing boards and the dental boards and pharmacy boards need to catch on as well. And so that people need to get the message that this is a movement towards health, and to normalize the human experience of sometimes needing to go for care to someone else, and to be able to do that in a safe way that doesn't lead to any threats on one's license.
I am very grateful to the Dr. Lorna Breen Heroes Foundation for championing the work that they have. The UC San Diego Health, just in the past year, completed our credentialing destigmatization. Have you ever been diagnosed with a mental health condition? Are you presently experiencing one that would impair your ability to provide safe patient care? It's small changes in the language that make such an important difference. Federal and state change, there are a couple things that come to mind. One, of course, funding creates a great opportunity to make a difference. I can tell you that as the program manager at UC San Diego, I do our accounting, I manage our budget. 85% of the funds we have committed to well-being go towards people's time, as in it takes people to do the work, not necessarily just buying plug-and-play tools off the shelf. And so I think funding is always an important part of it. Secondly, every state except California, unfortunately, has a physician health program. So, that's, some may be familiar with the discourse around there, coming and going. But having, of course, a safe external, psychologically safe, professionally safe external opportunity for folks to experience substance use rehabilitation or other professionalism opportunities. Something that comes to mind for us in California is a state intervention. And then as another state intervention, of course, I've worked for the University of California. We have 7 medical campuses across the state of California, largest employer in the state of California, and of course a state institution. We're putting together what's becoming a more formal workforce well-being, physician well-being leadership group at the University of California level, because so many of these policies that affect administrative burden and clinical practice and taxation on universities' sites comes from the University Office of the President. And so that's something that we're working on as well at the state level, is creating collective collective voice and collective inertia, because we have these informal conversations. Well, you're dealing with that too. You're dealing with that too. Well, let's get together and talk about it and see if we can make a difference here.
Amazing. Thank you both. Questions online?
So we have one question on how do you monitor, evaluate, and report on the intended or unintended consequences of these workforce well-being efforts, specifically on patients, caregivers, quality of care, quality of life? Are you tracking all of that?
So it's been on our minds the past couple of years because, we know from the literature about the relationship between team health, workforce well-being, and the downstream, the cascading effects on quality and safety and experience. At some point you have to build the infrastructure to be able to measure those things, and that's something we're starting to take a serious look at. Because, some of the data that was shown earlier, our colleague at Press Ganey, makes a difference. And especially if I know there was the comment earlier about not measuring for measurement's sake, but I'm kind of one of those people that likes to see, okay, well, if we have existing infrastructure, can we derive insights from it? So that's, intended, unintended consequences. I think we're looking for value where we can find it. One unintended consequence, again, my work is focused specifically on physician well-being, but again, when you start singing the song of let's make things better, everybody wants that. And so well-being grows pretty rapidly. And, we've been doing our physician wellness program was formalized right around the time that the national plan was published in the fall of 2022. We've had well-being surveys since then. They've only grown in scale, and the strategy's only grown in scale and complexity. We'll be expanding our well-being survey and strategy to our entire 20,000 health workforce next month in January. We're in the middle of that right now. So it's unintended, semi-intended, but certainly the right thing to do because people are talking about it now.
Just a follow-up to that, what are your accountability measures and part of your role? Is it retention of your 1,700 physicians?
Yeah, it's been an interesting point of discussion because, like many of us, we get this substantial panel of metrics, and they mean different things to different people, and at the end of the day, you have to do meaningful work. And so what we've identified, there's kind of two sides to it. If you think of like a parallel of the the United States government has like a federal and a state system. We kind of have like a health system and a departmental kind of joint ownership of wellness interventions and portfolios. The perioperative specialties have measures that are really important to them, and that is what is tracked year over year closely. Medical specialties have that equivalent thing. Emergency specialties have the equivalent thing. So the answer to your question is that the metrics we've largely focused on process measures in these first few years, and we've largely supported individual areas in working meaningfully on the process measure-oriented work that is most pertinent to them. And then at the health system level, what we do is we identify, are there systems or policies that cannot necessarily be influenced at the department level that must be taken on by an institutional level. And then that's the work that our office coordinates. So for instance, working with our colleagues in IS to deploy ambient documentation, it goes everywhere. And it takes funding and coordination, those sorts of things. So more of the local process measure focus so far.
One other area I wanted to share about measuring, before I came here, I called my colleagues at the Recovering Professional Program in South Carolina and told them I was going to be talking with you all today. And the director shared with me that over half of the physicians in the Recovering Professional Program have entered that program voluntarily. And so one way of measuring might be how many people are choosing to move towards health rather than risk not getting help because of fear that something might happen. So that's one thing. The other thing is when you talk about what has been published in the literature regarding outcomes of treatment provided to physicians in health programs, and the success rate is very significant in those individuals who have been able to find and move towards a clean and sober lifestyle to be able to continue to practice medicine. But it's not 100%. And that speaks to the severity of the illness itself of addiction, is that some folks with everything going for them still remain impaired and unable to practice. So we put our best foot forward. If we don't have that opportunity for licensees to get that kind of help, how many are we losing from the workforce that we really need to continue to provide care to our citizens?
Thank you. Thank you for sharing that. Have a question in the room?
Yes, hi. So my name is Chantal Brazeau from Rutgers Health, and it's more of a comment and a slight follow-up question for Habib. When you mentioned empathy and compassion as really part of the strategy, that really resonates with me. I find that sharing survey results in an empathic, compassionate, supportive, psychologically safe way makes a huge difference. And in my experience, it's led the way to transparency, because then it's more easy then for people to start talking about it and for results to be displayed by changing the culture, that the results can be displayed in a more transparent way, and then it can be talked about like any other quality measure is talked about. And that's been a journey in our organization. It's taken about 4 years to get to the point of transparency. I do believe that empathy and the compassion was the key element to bring it to that. And I'm just wondering if you can share any thoughts about transparency.
Yeah, certainly. So it actually kind of relates to the question about choice of measures. First of all, a large part of our experience at UC San Diego has been the, I think, amazing and courageous and caring decision of our CEO and other senior leaders to commit to transparency in our data sharing, to commit to being at every single one of these department meetings and physically present, to create a human connection and an opportunity to have a connection of, to create the opportunity for empathy, the opportunity for me to share in your feelings, and then express my compassion, each of us to express our compassion as somebody who wants to do, wants well-being for other people. And the reason I mentioned it's related to measures is because we do measure outcome measures complete burnout, individual burnout, turnover intention, looking at other jobs, and a number of other related measures. But it's the conversation that helps you reconcile, like was mentioned earlier, does this reflect my lived experience? And again, that's when you get a layer deeper. Well, this thing just drives me nuts. So let's focus on the thing that drives you nuts, rather than just saying, yeah, the state of the department is 50% burnout, et cetera, which of course is an average of a range of people's experiences. And also, I'll just say that without creating that space, that safe space, it's really easy to misinterpret data too. I'll give you another example. In the first year, our department of neurosurgery was one of the first departments to volunteer to take the well-being survey, the very first year. And one of the measures that is in our survey is workload, total hours worked, and theirs was something like 72, in the range of hours worked, it was definitely on the high end. And so we came to them, you have this workload issue, people are working way too hard. We see in our data that after a certain number of hours worked, burnout tends to spike. And they were like, no. We love what we do, and we want to do as much of it as we want to do. So don't worry about reducing our total workload. Please focus on this administrative burden or these inefficiencies that grind my gears because I just want to take care of people, and this stuff drives me nuts. And so it was interesting because we were attracted to one measure that lit up, but we misinterpreted it because we thought we knew something, but it was only by being in the physical space that we got the opportunity to connect and see what was where we ought to direct our attention. And then that was, again, going from when we learned, like, okay, so maybe it's some of the process measures that are more useful and meaningful to certain populations.
Thank you.
But it also sounds like the survey was a conversation starter. They were asked, and then you followed it up with a conversation.
Yes, it was a conversation starter, not the end of the conversation. Now, of course, we referenced the data, but it wasn't that singularly the data made the strategy. It was the data initiated the conversation that led to the plan.
Very cool. Thank you. We've got another question in the room.
Yeah, I was wondering if we could shift back to this conversation about policy, right? Thinking about, again, system level solution. And there has been great work done indeed on medical licensure applications. And, the next frontier is hospital credentialing questions and malpractice litigation sort of signing up questions and the rest of it. But I wonder, perhaps this is for Dr. Lombardi, what are we not thinking of, right? Like, where else should we be thinking about, policies, whether it's at the national or state level or even at our own organizational level? One policy that we recently changed at University of Colorado was, for example, just when employees are eligible for paid parental leave, right? You can just imagine taking neurosurgeon, right, perhaps have delayed pregnancy, finally get their first job, and sorry, you have to wait a year. So now that's at day one of employment, right, that everybody can get paid parental leave. But I'm just wondering, like, what are we not thinking of, right? Or what else should we, sort of start to lobby for or put our weight behind when we think about policies?
Thank you. Thank you for that question. I'd welcome my panelists' thoughts too. And as you were just mentioning, I was going to say, I think some of the policies would be good for all workers. Paid parental leave would be good for all workers. Affordable housing in the community you work, so you don't have a long commute if you're an environmental service worker and you've got to travel an hour in. So I do think some of these more the community, state, federal policies to support the quality of worker life, certainly. And then I was also thinking about some of the conversation and national discourse on conversations like nurse staffing ratios and how those conversations are in one part about patient safety, but also how can those conversations also be moved towards worker well-being. So thinking about, as the earlier conversation is, what can we learn from the patient safety policies and how can those be dual strategies? But obviously, as you could imagine, there's a lot of counter interest in policies like that. Even workplace violence legislation that we reviewed, it was so surprising. States that had horrific workplace violence incidents that made the national news had not expanded or extended their workplace violence laws on their state. And so really trying to think about where is the political will and capital is something for us to all think about. But certainly I'll have my panelists have any other thoughts on that.
I'm not sure that I have something to add to that other than to reflect on the fact that it seems like we're making progress. But when I was listening to Dr. Spiker earlier and in hearing about our medical students' fear of getting help or fear of disclosing because it might affect their ability through the dean's letter process or whatever to get into residency training, I was thinking also when we talk about generational things, we've come a long way, but somehow we've got to normalize getting help as a routine thing that's important for students, and maybe through generations this will get better over time. So we still have a lot of work to do.
And I'm blanking on who wrote this article, but someone really was, pushing out a really innovative idea of, is turnover a quality metric that should be evaluated in terms of payments? And so I know we've got CMS maybe hear a conversation later, but really thinking about ways that we support health systems in delivering care and how those pressures can trickle all the way down to the healthcare worker as well. But yeah, a lot of these are very big issues that with a lot of interest and not a lot of change. But I think what seems like a bright spot is that there's a lot of focus of that. It's not just even though, Habib, you have a beautiful program, the physician well-being program is not going to save this issue and save this problem. That can do an amazing job, but it's still working within a really burdened healthcare system. And so thinking about those strategies as well. Well, I think that is time. I don't know how we went through time so much. Thank you so much, Tim and Habib. We had a great conversation. Thank you for your questions, and I look forward to hearing what's next. Thanks so much.